Picture this. A new life enters the world, but instead of that first powerful cry, there's silence. In that moment, the clock starts ticking. Every single second counts, and the medical team has to follow a precise life-saving script. So let's dive in and see what that script actually looks like. In this explainer, we're going to break that script down. We're looking at the Neonatal Resuscitation Guideline, which is basically a clinical flowchart. Think of it as a blueprint for breathing, one that turns a moment of absolute crisis into a calm, coordinated response. So here's our roadmap. We'll walk through this thing step by step. We're going to start with the first assessment, then move into breathing and heart support, check out the advanced interventions, and finally, wrap up with how they get the baby stable for transport. All right, let's kick things off with Section 1, the first assessment. Seriously, everything that happens next hinges on the answers to 3 incredibly simple yet critical questions that have to be answered almost instantly. And here they are. It's a rapid-fire check. 1, is the baby full term? 2, are they breathing or crying? Are they making any noise? And 3, do they have good muscle tone? Are they active and moving, or are they kind of limp? These observations paint the whole initial picture in just a few seconds. So, right away, the path splits in two. If the answer is a big yes to all 3 of those questions, fantastic. The baby goes down the routine care path. But if the answer is no to even one of them, the team immediately pivots and heads down the intervention path. Now, if everything looks great, we're on the routine care path. This is what you hope for every single time. The focus here is pretty straightforward. Keep the baby warm, make sure their airway is clear, dry them off, and just keep an eye on them. It's all about providing a stable, warm welcome. But okay, what happens when things aren't so routine? That brings us to Section 2, the breath of life. This is for the newborn who needs a little, or a lot, of help getting those first few breaths going. So the next critical checkpoint is this. Is the baby's heart rate dipping below 100 beats per minute? Are they just gasping for air? Or are they having apnea, which is basically a pause in breathing? A yes to any of these is the trigger for the first major intervention. And that intervention is called positive pressure ventilation, or PPV for short. Now, it's really important to get this. It's not about aggressively forcing air into the lungs. It's way more gentle. It's about using a mask to give little puffs of air that help the baby's lungs open up and start doing their job. And this is where technology becomes absolutely crucial. The team can't just eyeball this stuff. They hook up a cardiac monitor and a pulse oximeter. This gives them cold, hard data, a precise second-by-second picture of the baby's heart rate and oxygen levels. No more guesswork. All right, now let's move to Section 3, where things escalate a bit. We're talking about supporting the heartbeat. This is what happens when just helping with breathing isn't quite enough to solve the problem. So the team has been providing that PPV we just talked about, but they are watching that monitor like a hawk. And here's the next huge decision point. Is the heart rate still below 60 beats per minute? That number, 60, it's a critical line in the sand. A heart rate below 60 means the baby's heart just isn't pumping enough blood and oxygen around the body. This is a major red flag, and it means the team has to start chest compressions immediately. And this isn't just one thing, it's a whole cascade of coordinated actions. They start chest compressions, but they also keep giving breaths, just not at the same time. They crank up the oxygen to 100% to make sure every breath is as effective as possible. And then, every 2 minutes, they pause briefly for a pulse check to see if it's all working. And check out the precision here. The target rate for compressions is between 100 and 120 per minute. That's not a random number. It's based on solid evidence about what gives the best chance of getting blood flowing properly. It's a really delicate, high-stakes rhythm they have to maintain. So what happens if even chest compressions and ventilation aren't cutting it? Well, that's when we enter the most advanced phase of this initial response. Welcome to Section 4, Advanced Interventions. We're talking about bringing in medications. First things first, before they can give any drugs, they need a way to get them into the system, and fast. That means establishing an IV line in a tiny vein, or, if that's not working, an IO line, which goes directly into the bone. Either way, they're creating a direct highway into the bloodstream. So what's going through that line? 2 main things. First up, epinephrine. Think of it like a jolt to the heart, telling it to beat stronger and faster. And if they're worried about low blood volume, they'll give a fluid bolus to help boost circulation, kind of like topping up the tank. And notice how the doses are super specific, all calculated based on the baby's exact weight. Okay, so let's say the baby is starting to respond. The immediate fire is out. But the job is far from over. That brings us to the final part of our blueprint, Section 5,
stabilization, and transport.
You see, the ultimate goal of this entire flowchart, from that first simple question all the way to advanced medications, is to achieve one thing: stability. It's all about building a bridge, getting the newborn to a safe and stable point so they can be moved to a neonatal intensive care unit, or NICU. And you better believe this handover is just as structured as the resuscitation itself. The team follows very specific protocols for transport, and maybe most importantly, they call the receiving hospital. This ensures the next team is 100% ready to take over the second they arrive, so no precious time is lost.
So, we end up right back where we started. It's pretty amazing, isn't it? We've seen how a series of simple yes or no questions on a piece of paper can guide a team through one of the most intense situations in all of medicine. It just goes to show you how a structured plan, when applied with incredible skill and speed, can turn a simple flowchart into the blueprint for an entire lifetime.